Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
All right, now we'll have Marianna Resner, who is a PGY2 EM resident at Memorial Regional Hospital, and she'll be presenting a journal club on the comparison of 8.4% sodium bicarb versus 3% sodium chloride in severe hyponatremia.
Here are a list of the abbreviations. And regarding disclosure, so I want to acknowledge that this article was originally presented at SAEM at the annual conference in 2025, and it was published in the Journal of Academic Emergency Medicine. So there are no funding or conflicts of interest to report regarding this. So regarding the study design, this was an objective study which evaluated whether a 50 milliliter bolus of 8.4% sodium bicarbonate produces a serum sodium increase, which is comparable to a 100 ml bolus of 3% hypertonic saline. And this was a retrospective multi-center cohort study, which was conducted at 2 hospitals in California between January 2019 and December 2024. So a little bit of background information on hyponatremia. This is primarily a disorder of water balance rather than sodium deficiency, and it occurs when there is excess body water compared to the total body sodium and potassium. And so this is most often due to inappropriate vasopressin or antidiuretic hormone activity. And so the clinical manifestations, that's going to be dependent on the severity of hyponatremia and the rate at which it develops. We know that in acute hyponatremia, the decrease in serum sodium can result in cerebral edema and severe neurologic complications, whereas chronic hyponatremia often presents with more subtle symptoms, and this is due to cerebral adaptation. Because sodium is the primary determinant of serum osmolality, reductions in sodium concentrations as well, that promotes water movement into the cells, specifically in the brain, and so that leads to many of the clinical signs and symptoms associated with hyponatremia that I'm discussing today. So this slide summarizes the classification of hyponatremia. It can be further classified based on volume status, so patients who are hypovolemic, euvolemic, or hypervolemic. In hypovolemic hyponatremia, both sodium and water are lost, but the sodium exceeds the water loss, and so some of the common causes include GI losses, burns, pancreatitis, and diuretic consumption. In euvolemic hyponatremia, the total body sodium is basically unchanged, and so the total body water increases. SIADH is one of the most common causes, and hypothyroidism and adrenal insufficiency as well can be a cause. And then hypervolemic hyponatremia, this is when both the sodium and water are increased. However, the water retention that exceeds the amount of sodium that's being retained. And so some of the common causes are heart failure, cirrhosis, nephrotic syndrome, and renal failure. And essentially what I want to highlight is that the patient's volume status is essential because it helps determine the underlying cause of hyponatremia, and this guides treatment as well. So this slide highlights the symptoms that define severe hyponatremia. So moderate to severe symptoms include nausea without vomiting, confusion, and headache, and severe symptoms include vomiting, respiratory distress, abnormal or deep somnolence, seizures, and coma. And so these symptoms are all concerning because they suggest that cerebral edema may be present due to the rapid shift of water into the brain cells. Moving on to the management of severe symptoms of hyponatremia. So for patients with severe symptoms, the European Journal of Endocrinology, their clinical practice guidelines suggest administering 3% hypertonic saline and giving a 150 ml dose of 3% over 20 minutes. They then recommend checking the sodium and clinical status after that bolus. And if the severe symptoms persist or the sodium has not increased adequately, they recommend giving another 150 ml bolus over 20 minutes. This process can be repeated up to 2 times or until the sodium has increased by approximately 5 points. The target is a 5-point increase, not normalization of sodium, and that's because there is a concern for overcorrection in patients. I also want to note that 8.4% sodium bicarbonate, this was not mentioned in any of the American or European guidelines. So now focusing on a comparison of the two agents being presented today, sodium bicarbonate and hypertonic saline, it's important to understand why sodium bicarbonate is even being considered as an alternative to hypertonic saline. So a 50 ml ampule of 8.4% sodium bicarb that contains roughly 50 MEQs of sodium and chloride within a very small volume. And because of this, it can essentially provide a rapid increase in sodium while minimizing the amount of fluid that we're administering to patients. And so some of the advantages include the fact that it can be administered easily, it has a higher sodium concentration per unit of volume, and can also correct metabolic acidosis if present. However, bicarb does have some limitations, so it can contribute to metabolic alkalosis, other electrolyte abnormalities, and I also want to highlight that there's less clinical evidence supporting its use for hyponatremia. In contrast, we have 3% hypertonic saline, and this remains the guideline recommended agent. It has been very well studied. It does require a larger volume for administration and does carry a decent amount of chloride as well. Now moving on to the study criteria. So patients within this trial were included if they were adults with a serum sodium of 120 MEQs or less and received either a single bolus of 50 ml sodium bicarbonate or a single 100 milliliter bolus of hypertonic saline within 12 hours following ED presentation. And there are some important exclusions that were applied to these patients, including other therapies that could affect the serum sodium concentration. So administration of isotonic fluids, desmopressin, or diuretics, those patients were excluded. By doing this, the authors were trying to reduce the number of confounding variables that were present and essentially trying to attribute that change in the sodium concentration to the study intervention itself. I also think it's important to note that patients with an initial elevated glucose greater than 250 were excluded from this trial, and that's due to the relationship between elevated glucose levels and hyponatremia or pseudohyponatremia. And so I agree with that exclusion criteria listed. So looking at the study population, of the 115 charts that were reviewed within this trial, only 42 patients met the inclusion criteria. 21 patients were included in each treatment arm. This does highlight one of the major caveats of this study, which is that the sample size is quite small. But I do think it's beneficial that the two groups were balanced, so each treatment arm had an equal amount. Looking at the statistical analysis, so for continuous outcomes, the investigators used a Mann-Whitney U-test. For categorical outcomes, they used chi-square testing or Fisher's exact testing, and that was dependent on the specific data distribution. A p-value of less than 0.05 was considered statistically significant, and one of the limitations was the absence of a priori power calculation. So without the power analysis, it's essentially difficult to determine whether the study was adequately powered to detect statistically significant differences, particularly relating to the safety outcomes in these patients. So moving on to the primary outcome and the secondary outcomes, the primary outcome was the proportion of patients who achieved a serum sodium increase of at least 4 MEQs per liter after a single bolus of one of the two agents. And the rationale for selecting this endpoint is that the guidelines recommend targeting an early increase in the sodium to improve neurologic symptoms. The secondary outcome was or included the changes in serum sodium, bicarbonate, chloride, anion gap, and the incidence of osmotic demyelination syndrome. And they also looked at variables from an operational standpoint, so the time from medication order to administration for both treatment arms. So for the primary outcome, reporting the results, roughly 48% of the patients receiving sodium bicarbonate achieved at least a 4-point increase in serum sodium compared to 10% of patients within the hypertonic saline arm. And the difference was statistically significant. Looking at the actual sodium change, the median increase was roughly 3 points in the sodium bicarbonate group compared with 0 points within the hypertonic saline group. And there were no statistically significant differences observed for changes in bicarbonate, chloride, or anion gap between the two treatment arms. In addition to that, there were no cases of osmotic demyelination syndrome that were reported in either treatment group. And overall, the sodium bicarbonate group appeared to have a higher effect on producing an early increase in serum sodium following a single bolus of administration of bicarb. However, I do want to caution regarding the interpretation of these results. So the hypertonic saline group, for example, they received a single 100 milliliter bolus. And so the current guidelines, as I listed them, recommend administering an initial 150 ml bolus along with repeat boluses based on patient response. So that comparator arm, that may not fully represent the guideline-directed therapy, but it is providing per volume an equivalent amount of sodium that's being administered to those patients. So I think there are several important limitations to consider when interpreting the results for the two treatment arms. First of all, this was a small retrospective study and there were only 42 patients, and so that increases the potential for the inability to detect other adverse events such as osmotic demyelination syndrome, or I should say outside of the osmotic demyelination syndrome. Secondly, the primary endpoint was like a surrogate lab marker rather than a clinical outcome. So while the sodium correction was an important component, the study did not evaluate the resolution of symptoms in patients, their neurologic recovery from start to finish, the length of stay, the mortality. So I think that's an important differentiating factor with the interpretation of these results, because we're looking at the improvement of a number rather than resolution of clinical signs and symptoms. In addition, one of the limitations that stood out to me was the lack of volume status assessment in the patients. And the authors reported precipitating conditions within the baseline characteristics of the patients. So looking at rates of heart failure, renal dysfunction, but it is also important to point out that these diagnoses don't necessarily indicate whether the patient had a specific volume status. So whether they were hypervolemic, euvolemic, or hypovolemic at the time of treatment. And so since the volume status influences the cause and the response to therapy, I do think that this could have an impact on the results. Additionally, the study did not assess overcorrection risk beyond the initial sodium measurement, and so that limits the ability to evaluate long-term safety. And finally, although the 50 ml ampule of sodium bicarbonate and the 100 ml bag of 3% hypertonic saline contain a similar sodium load, the hypertonic saline group, again, received only a single bolus. And so as I mentioned previously regarding the guideline recommendations, they recommend administering repeat doses based on response. And so that may not fully and adequately represent the guideline-directed management within that patient population. So the conclusions from this trial are that 8.4% sodium bicarbonate more frequently achieved early sodium correction goals compared with a single bolus of 3% hypertonic saline. And I think that the data does support this conclusion. The patients who received sodium bicarbonate were more likely to achieve a serum sodium increase of at least 4 and experienced a greater median increase in sodium. However, I would state that we have to be cautious with the interpretation of these results. From a practical standpoint, I think the biggest implication of this study is the feasibility. So you have a 50 ml ampule of the bicarb, and that provides the same sodium load as a 100 ml bolus of hypertonic saline. And because sodium bicarbonate is readily available in the ED, ICUs, code cards, etc., I could see it being utilized more frequently, especially in patients who are euvolemic or hypervolemic, and when additional volume may be undesirable in these patients. I also think it may have utility in patients presenting with seizures secondary to hyponatremia or cerebral edema, where rapid sodium administration is important and we need immediate access to therapy, and a delay in therapy could cause harm to the patient. And so overall, I think this is a great agent. Sodium bicarbonate needs to be studied more frequently with future retrospective and randomized trials. But hypertonic saline does remain the guideline-supported therapy at this time. But I look forward to its utility moving forward and the research that's going to expand upon its use. And that's all I have for today. I will open it up for questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.